Let's talk about Lewy body disease. Abnormal aggregates of protein within the neurons that occur in several diseases and is second most common cause of dementia. Fluctuating cognition. They're going to have various levels of tension, arousal level, varies hourly, daily, weekly. Here's where the difference is. Recurrent visual hallucinations, about 75% of the patient, can have Parkinsonism, facial immobility, posture instability, and gait difficulty. So let's go with this. How can we tell the difference between Lewy body dementia versus Parkinson's disease? To differentiate from Parkinson's disease, if the gait problems develops first and then dementia a year or two later, afterwards it's going to be Parkinson's. If dementia is first followed by Parkinson's, is likely to represent Lewy body dementia rather than Parkinson's. Less responsive. Why is this important? Because of the treatment. We have to get the right treatment. Less responsive to levodopa than Parkinson's disease. Okay, let's go through that again real quick. To differentiate Parkinson's disease from Lewy body dementia, if the gait problems develop first, then the dementia a year or two afterwards, Parkinson's. If the dementia is first, Lewy body dementia. Frontal temporal dementia, average age of onset is 50 to 60 years old and has two variant types that are present with prominent features. Behavioral variant, changes of behavior, personality, and executive function. Someone used to be sweet and nice. I know we keep kind of touching these. We're hitting these in multiple different ways so you can remember this stuff. Changes in behavior, personality, executive function. So if they used to be nice and sweet, all of a sudden they're angry all the time, this would be a sign. Apathy, disinterest, loss of empathy, loss of initiative. So if somebody was gung-ho their whole life and they're not depressed, you need to rule out depression. Increased emotional liability, impulsivity. Executive function and decision-making are affected early in the disease. Can have memory and visual spatial skills are preserved, however. Progressive aphasia, early changes in language function. Continue discussion, and then we're going to have a discussion on progressive supranuclear palsy. We're going to remember this one. We're going to give you this really quick thing to help you remember for boards. They can't walk down the stairs. They have trouble walking down the stairs. It's similar to frontal temporal dementia and presents with early postural instability and falls, axillary Parkinson's. They have trouble walking downstairs because they have trouble looking downwards. That's the thing you need to remember. Poor responsive to levodopa. Vertical gaze palsy, limitation of eyes movements in upward and or downward gaze. Can have slurred speech. Apathy, slow progressing speed, impaired executive function. Trouble walking downstairs. I'm going to keep saying that because that's the board question you're going to get. XYZ is having trouble walking down the stairs. You have these Parkinsonian symptoms. The answer is progressive supranuclear palsy. They're going to have difficulty swallowing. Currently, there's no medications available, but in the early stages may benefit from levodopa, may benefit amantadine or other medications used to treat Parkinson's. Yes, but they're going to have poor response to levodopa, as we said. There is no medications. This would be your board question. There's not going to be anything. May respond early, in early stage to levodopa, amantadine. Chronic traumatic encephalopathy. This is the one that's been in the news quite often. Progressive degeneration disorder from repetitive mild head injuries. Tau protein neurofibrillary tangles with differential distribution than in Alzheimer's disease. Typically 8 to 10 years after repeated head injuries. We forget about it, but soccer, when you're hitting the ball in soccer, repeated times of hitting the ball in soccer, this can cause chronic traumatic encephalopathy. We don't think about this. They're going to have poor short-term memory, executive function, poor judgment, can have depression, irritability, aggression. Yes, it can happen in football because you imagine in football, it's like it's 20 feet from your garage door and running head first into your garage door repetitively multiple times. It would be a professional football game, but this also can occur in sports such as soccer where you're heading the ball anytime the head is getting injured repetitively. Pharmacological treatments for cognitive symptoms. For hallucinogens, agitations, atypical psychotics can be useful. Atypical antipsychotics can be useful but are not FDA approved for these indications. There are black box warnings, increased risk of death by at least 60% within the first 10 weeks after starting antipsychotic medications. So what do we do? And I've gone to multiple lectures, read books, listened to podcasts on these great ones that have taken care of people with dementia and the cognitive problems that can go, and then the aggressive, there is nothing great. You can die redirection. Hopefully you have a greatly trained nursing staff and or nursing home staff that can help redirect these patients. Hopefully family can be involved and help redirect, but a lot of times this doesn't work. It doesn't work. And it's easy to sit back and say, hey, you can't give antipsychotics and let these patients beat your nursing staff and or nursing home staff like a rock'em sock'em robot. So hopefully these medications are coming along and they'll help us take care of these patients, because this becomes a real deal where patients can hurt themselves and or other staff and or other patients. What do we do for dementia? This is the important things. We need to get physical and social activity, manage the risk factors. We need to make sure that they can see right, have their glasses and hearing aids, check their medication list, anticholinergic NSAIDs inhibitors, such as donepezil, rivastigmine, MMAD receptor antagonist, memantidine. Now, these disease-modifying monoclonal antibodies, they have a huge cost. They can have brain bleeding and cerebral edema, and we're really not seeing the great changes. Now, remember, going back to the anticholinergic inhibitors, donepezil, the side effects can be weight loss, diarrhea, nausea. Remember these anticholinergic effects. And the disease-modifying monoclonal antibodies, the jury's still out. A lot of people question if they should have been approved or not. That's a political. We have no idea, and we'll have to watch over time. All right, let's get ready for another unfair question. Which of the following features most reliably distinguishes delirium from dementia? This is really important. Which distinguishes delirium from dementia? Gradual onset of symptoms, fluctuating course, and acute change in mental status. Delirium from dementia. Persistent memory impairment, absent of perceptual disturbances, normal level of consciousness. This is a 78-year-old woman who's admitted for pneumonia on day 3. Her nursing staff reports she's disoriented. She has difficulty maintaining attention, and her mental status fluctuates throughout the day. Her family notes she was cognitively intact prior to admission. This happens all the time. Happens all the time in your wards. It happens all the time in your ICU. And the families are angry because they brought this patient in here for you to get them better, and now they are worse. Now they are worse, and they feel that you have done this. So what do we have going on? What's the most reliable distinguishes delirium from dementia? It's going to be the fluctuating course and acute change in mental status. Delirium is characterized by acute onset of fluctuating course of inattention and alternating levels of consciousness. Distinguish it from dementia, which typically has gradual onset and stable course. Why is delirium important? Delirium is important because you have high morbidity and mortality. I've said this before. You can see physical changes of delirium from a patient pre and post on MRI. This is excluding stroke. So even if they had a stroke, you see the changes from the stroke. They have delirium on top of that stroke. You see the MRI, there's going to be further changes. Once this happens, they have a high risk of death. Can be up to 80% of death. And man, there isn't great stuff out there. You can try to manage and identify risk factors. You need to have mobility and physical activity. You need to make sure the lights are on during the day and off at night. Make sure they get good sleep, maximize the sleep schedule, optimize their environment, make sure they have their hearing aids and glasses on, avoid restraints. That's really easy to say sitting in front of a computer, but when they're running down the wards and punching other patients, other families, and hurting people, it's really hard to say that. You need to get the family and friends involved to see if they can help. So there's multiple things for delirium prevention. Vanderbilt did a great thing, and it's called the ABCDEF for delirium prevention in the ICU. A is assessment and prevent and manage pain. B is spontaneous awakening trials. So this is when patients are in event and spontaneous breathing trials. C is choice of analgesia and sedation. Remember, we want to reduce opioids and benzos. We want to avoid medications that are on the bears list, like diphenhydramine. D is delirium, preventing the delirium. And E is early mobility and exercise. F is going to be engagement and empowerment. There's also the hospital elder life program, which is called HELP, which can assist in patients with delirium in the hospital. I wish there was a medication that just stopped delirium. It would save lives. It would reduce costs, reduce hospital stays. And this is where you have to talk to the families, because families will be mad. This is something that brings a lot of anger. It's because they're like, we brought them in for pneumonia. Now the pneumonia is better, but guess what? Our family member is not the same person. And you have to be honest and say, this delirium may never go away. This may be an unmasking of underlying dementia. Someday we'll be able to pull blood out and run a test and say, yes, they had delirium on dementia. And we'll be able to use a medication to get these patients better. But right now, we're stuck in a very difficult situation.